Hi guys, welcome back. So yesterday we stopped at abnormalities of placenta. So let's continue ahead. Now the umbilical cord initially has four vessels. Right umbilical artery, left umbilical artery, and right umbilical vein, left umbilical vein. One of them vanishes. Which one is it? Easy to remember. V for vanish, V for vein. So vein vanishes. Which one, right or left? Left vein is left, so right one vanishes. Okay. So finally, there are two umbilical arteries and left umbilical vein in the umbilical cord. But sometimes, instead of two umbilical arteries, there is only one umbilical artery, and this is not normal. This is abnormal condition, and it may be seen in diabetes if the mother has diabetes, or in twin pregnancies. And this is associated with some CVS and renal abnormalities, as well as sometimes it is associated with trisomies in fetus. Right. So there's one disorder of umbilical cord, that is Vilamintus insertion of umbilical cord. What is this? So the umbilical cord inserts in the membranes, and those branching vessels are also present in the membrane. Right, and if this branching vessels along with in the membrane are present just below the presenting part of the fetus, suppose the presenting part is head. So if these vessels, these vessels present in membranes are present just below the presenting part, it is known as Vasa Previa. The name is very appropriate. See, Vasa is vessels, so these are blood vessels. And what is previa? Pre is just before, and via is via, via, via. So how is the fetus going to come outside? Via cervix, right? So it is just before the cervix. That's why it is known as Vasa Previa. And this is very dangerous condition because whenever we do artificial rupture of membranes, these vessels may get ruptured and there might be bleeding, and this bleeding is from the fetus. So sometimes we need to differentiate whether the blood which is coming through the cervix or through the vagina is of the fetus or is of the mother. So for this we do a test known as Apt Test, APT. It is named after a scientist, and the other name for this test is Singer's Alkaline Denaturation Test. Okay, so what is the principle of this test? Basically, fetal hemoglobin, which is HbF, is resistant to alkali, but Hba is not. So we use this principle, we collect the blood, we add an alkali, either NaOH or KOH, and see at the color change. If the color of the blood changes to brown, which is mostly due to hemolysis, we can say that the bleeding was from the mother. If there is no hemolysis, the bleeding was from the fetus. Okay. Positive Apt Test is seen in fetal blood, and negative Apt Test in maternal blood. Right. Now let's move on to the amniotic fluid. So as you must have studied that there are two cavities in the initial development period. One is the amniotic sac and the other one is yolk sac. Amniotic cavity and the yolk sac. So whatever the amniotic fluid is there, it's present in the amniotic sac, and eventually this amniotic sac covers the entire fetus except at the part where the umbilical cord is attached. Right. So this amniotic fluid is slightly basic, and what is its major source? So during initial few weeks of life, the major source is from the plasma of the mother. But as the fetus develops and his renal system also develops, the major source becomes the kidneys after around 20 weeks. Okay. And how is it drained? The fetus swallows this fluid through his GIT, and that's how the drainage happens. Okay, so after 20 weeks, the main contributor to amniotic fluid is renal system, and main absorption or main drainage is through GIT system. Okay, so you all may be knowing the function of this amniotic fluid. But one thing I would like to highlight here is that amniotic fluid does not have any nutritive role. Okay, other functions are there like shock absorption, temperature regulation, etc. Okay, so the amount of amniotic fluid goes on increasing and is maximum around 32 weeks. So at 32 weeks, its amount is around 1 liter. And after 32 weeks, it goes on decreasing. At 36 weeks, it's about 800 ml. Okay, so in abnormalities of amniotic fluid, there can either be an abnormality in the color or quantity. So let's first see abnormalities of the quantity. If the quantity is low, it is called Oligohydramnios, and when the quantity is more, it is called as Polyhydramnios. Right. So how can we determine that whether this amniotic fluid is less or more? We can't just randomly say that this is less or this is more. We need to have some specific criteria. So for that, we have three main criteria. First, either we can directly measure the volume, okay, or second one, we can see the size of the pockets. Yeah. So volume, if the volume is less than 200 ml, we call it Oligohydramnios. If the volume is more than 2 liters, we call it Polyhydramnios. So we have a wide range from 200 ml to 2 liters. Okay, but nowadays we prefer to measure the size of the pockets. So we can either measure the size of all the pockets. So we divide the abdomen into 4 quadrants. Okay, and we measure the size of the largest pocket in each quadrant and add all of them. This is known as Amniotic Fluid Index, AFI. So normally this total addition is between 5 to 24 centimeters. Anywhere between 5 and 24 is normal. If it's less than 5, we'll call it Oligohydramnios, and if it's more than 25, we'll call it Polyhydramnios. But the most sensitive test is to measure single largest vertical pocket. So in the entire abdomen, we see which one is the largest pocket, and the length, the measurement of that largest pocket should be anywhere between 2 to 8 centimeters. If it is less than 2, again oligo, and more than 8, poly. So we do this by USG. Right. So now let's see about Oligohydramnios and Polyhydramnios. Can you guess what would be the cause of Oligohydramnios? Exactly, right. So any abnormality in the renal system, because renal system is the main system which helps in formation of amniotic fluid. What are the other causes? Some drugs like Indomethacin, ACE inhibitors can cause Oligohydramnios. I would like to tell you one fact that Indomethacin, what does Indomethacin do? That is that it dilates the efferent vessels. Efferent. Okay. So whatever blood is coming to the kidneys from afferent vessels will be drained faster through efferent, and the GFR production will be less, and that's how the amount of amniotic fluid formed will be less. Okay. The other causes are maternal hypertension, then premature rupture of membranes, and one trisomy 13. Okay. Now let's see about Polyhydramnios. So similarly, you can guess what will be the cause of Polyhydramnios. Any abnormality in the GI system, like esophageal atresia, duodenal atresia, any sort of atresia. Okay. Other causes can be maternal diabetes, that will lead to fetal hyperglycemia and eventually more urine will be formed. Multifetal pregnancy, and trisomy 21. So now let's see effect of oligo and polyhydramnios in pregnancy. So in oligohydramnios, there is less space available for the fetus. And one thing I would like to add here is that amniotic fluid is important for the development of fetal lungs. So in oligohydramnios, already there is less amniotic fluid, plus the space available for the fetus is also less. So this can lead to pulmonary hypoplasia, which is the most common problem occurring due to oligohydramnios. In polyhydramnios, there is stretching. There is excessive amount of amniotic fluid and there is stretching. This stretching can lead to abruption of placenta, abruptio placenta, and malpresentation. Since the fetus has lot of space to move around, most of the time the baby can present as malpresentation. Okay. Now, if the oligohydramnios occurs later in pregnancy, where all the structures, all the organs of the fetus are developed, lungs are also developed. So how will it affect the fetus? It puts the fetus into stress, and there is decreased blood supply, and this can lead to fetal distress, which can lead to meconium aspiration syndrome. Right? So now we saw the causes of both oligo and poly. We saw their effects. Now how will we treat them? So treatment is difficult for both of these conditions. Most of the time we just observe, and whenever it's critical we mostly go for delivery. But for oligohydramnios, what we can do is we can do amnio infusion with normal saline. Externally we can infuse normal saline and try to maintain the volume of the amniotic fluid. In polyhydramnios, what we can do is we can do amniocentesis, but this is not very commonly done because it rarely may lead to abortion. And we can give Indomethacin. So in the causes of oligohydramnios, we saw Indomethacin was there. So we can make use of Indomethacin and use it to treat polyhydramnios. So now we saw the abnormalities of the volume. Let's come to abnormalities of the color. Normal color of the amniotic fluid is colorless to straw colored. But if the color is different, we can predict what abnormality may be there. Okay. So if the amniotic fluid is green in color, it is mostly that the fetus has passed the meconium, and we know that the color of the meconium is greenish. So that's why if we see green colored amniotic fluid, the cause of that condition must be fetal distress, and because of that fetal distress, the fetus has passed meconium. The other color is golden color. Golden color is due to unconjugated bilirubin. Okay, and unconjugated bilirubin is released due to hemolysis, and hemolysis is mainly seen in Rh incompatibility. Okay. Next one is dark red colored amniotic fluid. What does dark red color suggest? It suggests fresh bleeding. Fresh bleeding occurs in abruptio placenta. So if the color of the fluid is dark red in color, that suggests abruptio placenta. Other color is tobacco juice color. The name itself gives us the idea, tobacco juice. It means that there is IUD, intrauterine death of the fetus. And the last one is yellowish green color, that is seen in post-dated pregnancy. So that's it for today. We'll continue tomorrow. Okay? Till then, keep studying and enjoy. Bye.